Good afternoon, everybody. Hello, welcome. Hope everyone had a fun Halloween night or whatever we all celebrate. Happy November. Welcome. So glad you're here in person. My name is Sarah Dash. I am president and CEO of this amazing Alliance for Health Policy. And as we like to say at the Alliance, this is really your alliance. We are created sort of by and for congressional staff, the health policy community in a very bipartisan way. And so, in a stakeholder neutral way as much as possible. So we appreciate you all being here in person and braving the blustery day. How many people is this your first Alliance briefing? Welcome. All right. Welcome for venturing out. Thank you. If you've been to an Alliance briefing before, maybe you can take some time to meet a new person. We're really honored to have you here. So, for 30 years, the Alliance has been a trusted educational resource for current and future health policy leaders, and we take that role really seriously. We look forward to continuing to convene meaningful conversations on pervasive health policy challenges like the ones we're going to be talking about today. So, if you don't already follow us at allhealthpolicy.org or on LinkedIn, definitely check us out. One of the things we take very seriously at the Alliance is our role to listen first. So, in a town where a lot of folks are trying to get their opinions through, and for very good reasons, we get that. We have the role of being listeners and listening to multiple perspectives, and that includes your perspectives, and then we try to incorporate that into our programming. So I'm really excited for today's program, which I'm always going to be like a failure at tech. Oh, there. Oh, look at that. That was cool. Okay. So, okay. So today's briefing is the culmination of what we call our signature series. And the signature series that the Alliance does is a year-long focus on a particular issue. And this year, our series has been focused on the idea of envisioning a person-first health system. And so what does that mean? Well, you might hear the terms patient-centered, patient-first. We went through a lot of conversations and really landed on this idea of person first. How many of you have ever had to respond to a constituent letter? Anyone? Constituent? Yep. Okay. All right. Like, listen to your relatives complain about healthcare? Anyone? Raise your hand. Raise your hand. All right, come on. It's almost Thanksgiving, y'all. You have like a month to get ready because I know they're going to be asking you questions about our healthcare system, right? And so this idea of a person-first health system really comes about with, the idea of when we say people, we are talking about Republicans, Democrats, no matter where you live, rural, urban, right? Like no matter your race, ethnicity, gender identity, like age, any of that stuff, right? How do we collectively create a system that works for people, okay? And that is our responsibility as people in the policy community. So what we did as part of our signature series is we brought together a very diverse group of thought leaders and experts and community leaders and people, and came together in two very interactive workshops. You can see the evidence there, Exhibit A. There were sticky notes, and it was very exciting. And what came out of those two convenings really consisted of personal stories, people trying to navigate the healthcare system, what the public truly needs. And we asked sort of this idea of what does good look like, okay? And I'm sure you all have your own ideas of what good looks like to navigate the care system, the role that innovation can play, and what we're here to talk about today, the critical role that the healthcare workforce can play and needs to play, because we cannot have, and our thought leaders were very clear, we cannot have a person-first healthcare system unless we have a workforce that is supported and capable of delivering that person-first care. And then by listening to those of you in our bipartisan health policy community, we knew that you really wanted to explore these ideas about the workforce and how you as policy makers and people who kind of hold the pen can really help, right? So we are thrilled today to have an expert panel that is going to be talking about these issues. It is going to be an on-the-record conversation. A recording will be available on our website. This wonderful gentleman in the back is going to make sure of that. You can follow us on LinkedIn, etc. Okay, we are going to have a really exciting keynote speaker who I'm going to introduce in a moment, followed by this amazing panel, which will be expertly moderated by Farida Ahmed, who is right here. She is Associate Program Officer at the National Academy of Science, and she's going to introduce our panelists. So before we get to our panel, I am now pleased to introduce Sheila Pradier-Williams. Sheila Pradier-Williams, Deputy Associate Administrator of the Bureau of Health Workforce at HRSA, the Health Research and Services Administration at HHS, and she is going to be our keynote speaker. She has an amazing resume. She provides incredible leadership. She has a passion for HRSA's mission, as I'm sure you are going to hear, to achieve health and achieve health equity through access to quality services, a skilled health workforce, and innovative programs. And she previously served in leadership roles within the Bureau of Health Workforce and its predecessor bureaus, and with HRSA's HIV/AIDS Bureau. So, Sheila, thank you so much for joining us today. Really appreciate you.
Thank you for that wonderful introduction. I'm very pleased to be here today to talk about just that, the workforce and patient-centered care, and how the workforce certainly is a necessary part of that if we want to enforce that and strengthen it here in the United States. So basically, in my role as the deputy, I'm over co-lead of the Bureau of Health Workforce. And in HRSA, Health Resources and Services Administration, a big part of the work we do is around health equity, making sure that underserved communities, those who are geographically isolated, who have economic issues as well, and really need access to health care, to make sure that they can have access to health care in a number of ways. And the way in which I'm particularly involved is through the workforce, making sure that that workforce is prepared to do it. So next slide, please. Oh, sorry. So I'm sure it will come as no surprise to anyone that we have health shortages. I think it's everywhere. It's been in the news, and it's in the newspapers. It's in, when you open your iPhone and you get updates. So there's usually something going on around health workforce and the shortages that exist there. And so it's no surprise as well that we already had some workforce shortages and some supply issues, but COVID really exacerbated that in a number of ways. And so about 79% actually of the healthcare workforce has been affected by shortages. And so it is something that we in HRSA and the Bureau of Health Workforce are really engaged in trying to address. And if you're going to have patient-centered care, you certainly need to have an adequate supply. And we talk a lot about adequacy, about having enough of, so where the supply meets the demand and people can actually access that care. And so when we look at some of our projections, so we have our National Center for Workforce Analysis. We provide projections on some key areas of workforce. And so those include primary care, which we see now. We've just updated these numbers, and so our projections were just updated last week, and so this is fresh. But I want to caution, even when I give the numbers, that it may not show the full effect of the pandemic, and so we still are looking at how COVID even changed the behaviors of those who are seeking care, as well as how it's affected the workforce in terms of burnout, retention, and those things. So when we look at primary care physicians, we see that we have a 68,000 plus shortage of providers. And we see that in behavioral health, we also have quite a substantial shortage of providers, as well as in oral health, in maternal care and OBGYNs, as well as LP and nursing. And so one of the points that I'd like to make is that we see these shortages in terms of the supply versus the demand, but we also see that their shortages are more acute and well, chronic as well, in non-metro areas. So the adequacy is even less so in non-metro areas. So an area for us to that we really pay attention to in the bureau. And so, as we look at addressing these issues in the Bureau of Health Workforce, we have certain areas and certain aims that we want to achieve. One is to increase the supply, and so in our programs and in our funding, usually you will see one of these levers being pulled in order for us to try to right size the workforce, if you will. So one is supply, which is dealing with the pathways in which individuals go into the health workforce and become providers. And so we have a lot of programs that are, well, some programs, I wouldn't say a lot, but quite a few programs that are focused on that pathways, getting folks into the health careers and increasing that supply. The other is about distribution. So sometimes with some of the health professions, it is really not about the actual supply, but the fact that there's a maldistribution. So you have some areas of the country that may have an oversupply, while other areas of the country may not have enough. And so that's another issue that we look at through some of our programs, especially our direct service scholarship and loan programs like National Health Service Corps and Nurse Corps. Those are programs that address that maldistribution through loan repayment and scholarship. We also seek to advance health equity. So another part of that is, where's this workforce coming from? Is it diverse? Are we pulling and bringing people into the workforce who are from rural and underserved communities? And so do you have people who speak the different languages or the languages of the population that they're serving? And so those are the kinds of things that we're also focusing on. And then, of course, really trying to promote the resiliency of the workforce, looking at those systems type issues that sometimes cause burnout and cause people to leave the field. And so we do know that during COVID, quite a number of folks also left the health professions, especially around in nursing and some other professions. And then, of course, we try to amplify our impact by making sure that that whole pipeline from training, from education to training and service, we fill in that whole pipeline so that we have individuals who are prepared, who've practiced and trained in community-based settings to go back and work in the areas where we need them to work. So some of the drivers for success. So when we look at, how are we going to improve the workforce, the quality, the supply, there's a bunch of different levers that we will employ. And one is to recruit students from the communities where we want them to serve, because we know that that makes an impact. Individuals are more likely, if they're from a disadvantaged background or if they're from a shortage area, to go back and work into those areas. And so we know that is one of the things that we seek to do, and one of the targets that we have in a lot of our programming is to target individuals from the communities where we want them to serve. Another is to train students in underserved communities, as well as to support community-based training. So all of that kind of flows together. And then to leverage our loan and scholarship programs. So a lot of times what we hear is that individuals who come from economically disadvantaged backgrounds are hesitant to take on student debt. And so if you can provide scholarships and loan repayment in return for service, that is very helpful. And then, of course, when we look at how do we combine or integrate things like behavioral and primary care, how do we make sure that folks are trained in a team-based environment? So a lot of our programming aims to do that as well. So when we look at some of our outcomes, this next slide really is about some of the outputs and the outcomes that we have had in the programs. And so when we look at our pipeline and diversity programs, much like what I talked about earlier, these are some of the numbers we've trained, over almost 300,000 in our pipeline programs, meaning taking people who were not, who were either students or who may even have been in a paraprofessional area of practice, maybe CNAs, like your certified nurse assistants or something, and then taking them through a career pathways where they can become maybe a nurse, or maybe they can become a behavioral health specialist. The other thing is, in our loans and scholarships programs, we also have seen quite a big jump in our numbers, especially with the ARP dollars. We had a lot of individuals who came through the programs who are now able to practice, and we had a field strength of over 24,000, which is the first time in history that we've had that many individuals actually practicing in those areas. And then so you can kind of go and see, these are just our training numbers for medicine, our behavioral health, nursing. And so these are individuals that are either entering into the profession, most of them entering into the profession through our training programs, and also some individuals who are then already health professionals, but then who are being steered into either primary care or being steered into areas of underserved areas. So when we look at some of our cross-cutting measures for the program, we know that, so we have targets for our program. And so about 77% of our programs are clinicians who have been provided training in community-based settings. And so, as we set targets for people to train in these underserved areas. We set targets for them to be in underserved communities and training sites. And so this is sort of like the outcomes of what we've been able to achieve through our programming. And so these are very important benchmarks that we try to meet. And we have some that we are still developing. Sorry. So if you see the number of completers and graduates who are minorities, this is going a long way to increase the diversity of the health workforce. About 46% of all of the people who came through our programs were underrepresented minorities, or they came from disadvantaged backgrounds. As well as 59% of our alumni go on to serve in underserved communities. And so that's a baseline there for us. And so in future years, we want to achieve even more than that. So one of the things that we really focused on is our clinical partnerships. And so in order to make all of this happen, it's not sufficient to have just academic institutions sort of providing, education, but you've got to sort of piece the whole pipeline together, the pathway together, which means there has to be partnership at the academic level, there needs to be partnership with the clinical sites, and there needs to be partnerships with community colleges, and all of these come together. Our federally qualified health centers, rural health centers, and the like, our tribal. They're very important partners for us, and we've looked at ways in which our funding can extend to them, because they, many times when they're able to train, they're able to retain those providers. And so we know that is a very critical point for our programs, and something that we've continued to do and to focus on as we go forward. So some of our programs, and I'll go through them very quickly. So some of our priorities are around supporting mental health, and especially youth mental health. One of our policies is to make sure that there's no wrong door. So behavioral health and primary care integration is very important, and these are some of the programs that we've funded through the bipartisan Safer Communities Act. We funded primary care training and enhancement program in January for about, I think we funded about $58 million in that program. And so the others are like our behavioral health workforce and education program for child, adolescent, and young adults, and our pediatric specialty loan repayment. So all of these are expanding providers to deal with mental health, especially when it comes to youth. In terms of expanding access to primary care, again, we have a constellation of programs that have been funded in PCTE, we call it PCTE, and especially our Teaching Health Center, which is up for reauthorization right now, but that program is residency, and it takes the residency training out of hospitals and puts it in communities. So again, doubling down on how do we get primary care providers in communities. And then, of course, growing our nursing workforce. In August, we announced about $100 million to increase the number of nurses, our registered nurses, advanced practice nurses, nurse midwives, LPNs who largely work in long-term care facilities. And so we've not only looked at creating a pathway for individuals to go into nursing, but also looked at how we could train and to strengthen the nursing faculty component and nursing clinical preceptor component. The same thing with public health. We've really looked, when we talk about patient-centered care, you know, we invested a lot, $244 million in community health worker program, and those are the individuals who are the trusted individuals in the community that connect people with care. We also provided scholarships to the public health workforce through the public health training centers, and then funded preventative medicine residency programs. And so certainly here are some of our resources that you're welcome to take advantage of to get data. We have dashboards on the workforce, and we invite you to connect there and get more information and data. Thank you.
All right. Thank you so much, Sheila. That's amazing work, and thank you for sharing some of those results. So now turn it over to you, Farida, for moderating our panel. Thank you. And let me give you the clicker. There you go. Fabulous.
Hi, everyone. My name is Farida Ahmed. I'm the Associate Program Officer on the Action Collaborative for Clinician Wellbeing and Resilience at the National Academy of Medicine. Prior to this, I was an emergency medical technician and a social worker in New York City. I also obtained my master's in health science with a focus on healthcare, epidemiology, and risk sciences at the Johns Hopkins Bloomberg School of Public Health. So I'm very happy to be here today with you all. And today's event, as Sarah spoke about, will focus on giving a practical overview and takeaways about the healthcare workforce in order to be able to give that person-first health system. We're going to explore the opportunities and challenges of envisioning a person-first health system that prioritizes the healthcare workers. We're going to also discuss the current realities of the healthcare workforce, address workforce shortages, discuss optimizing workers to the best of their abilities, and how to build a robust workforce for the future. And so you're going to hear from 4 amazing speakers, including myself, and I'm going to give a brief introduction of all these speakers. So first, we have Dr. Patricia Pittman, who's the Fitzhugh Mullen Professor of Health Workforce Equity at the Milken Institute School of Public Health, George Washington, and the Director of the Mullen Institute for Health Workforce Equity. Dr. Pittman built an extensive research enterprise focusing on policies that enable the health workforce to better address health equity, including protection of labor rights of health workers themselves. And she's currently she directed the HRSA-supported Health Workforce Research Center that's now called the Workplace Collaborative, among several initiatives that she's worked on. Next, we're going to hear from Dr. Muriel Bean, who is the Senior Vice President and Chief Health Informatics Officer at Trinity Health. Dr. Bean is responsible for strategic and visionary leadership in communicating complex trends to influence change, to improve the impact of informatics on the system of care. She also advances the activities of health informatics and analytics and support efficiency and effectiveness in the healthcare operations with the primary goal of advancing evidence-based health practice through data, information, and dissemination of knowledge and wisdom. And finally, we're going to hear from Dr. April Joy Damien. Dr. Damien is a psychiatric epidemiologist, health service researcher, and classically trained public health professional and with expertise in health equity, social determinants of health, and mixed methods. She currently serves as the Vice President and Director of Weizmann Institute and which is a national research, education, and policy center dedicated to innovation and impact in primary care for the underserved. Dr. Damien also is a senior scholar for health equity at Academy Health and also holds a faculty appointment at Johns Hopkins School of Public Health, my alma mater. So before I turn it over, I'm gonna give a brief overview at what we do at the National Academy of Medicine and the Action Collaborative for Clinician Wellbeing. So I titled it Activating a National Movement for Health Workforce Wellbeing, because in order to be able to have that person first health system, you need to prioritize the well-being of the health workforce. And so I know we've spoken a lot about data, and so sometimes I'm very hesitant to talk about data and to talk about the burnout crisis, because I feel like we already know. And so I think it's about time we talk about solutions, talk about moving forward and what next in the future. So I'm just going to skip over this and give a brief background on the National Academy Clinician, which now is the health workforce, because we want to be very inclusive. So this was established in 2017 as a public-private partnership committed to reversing trends in the burnout that we see in the health workforce. We have the co-chairs, Dr. Victor Zhao, who is the president of the National Academy of Medicine, Dr. Dara Kirch, president emeritus of AAMC, Dr. Vivek Murthy, who is the Surgeon General, and Dr. Thomas Naska, who is the CEO of ACGME. And so the goals of this collaborative was to raise the visibility of clinician burnout, depression, moral injury, and suicide, improve the understanding of challenges to health workforce well-being, advanced evidence-based multidisciplinary solutions that will improve patient care by caring for the caregiver, and also laying the foundation for long-term culture change, and that's what we're really focusing on this time. We have different members, including some of the sponsors for this series, that are part of our collaborative, because it's a joint effort, and our steering committee comprised of members from the government, different professional societies, health IT companies, and all. So, as I said in the goals, before I go into this, it was always academia research consensus report. So in 2019, the collaborative published a consensus report that was titled Taking Action Against Clinician Burnout, which is a systems approach to professional well-being. But that was like talking about frameworks and systems level changes that could be done. And we felt like we needed to move forward. We needed to have like action plans. And so in 2022, the Office of the Surgeon General, and our president usually jokes as it being like a 1-2 punch, released the advisory on building a thriving health workforce. And we had the National Plan for Health Workforce Wellbeing. And the vision of the national plan was that people are cared for by a health workforce that is thriving in an environment that fosters their well-being as they improve population health, enhance the care experience, reduce cost, and advance health equity, and therefore achieving the quintuple aim, which everyone wants to achieve. And one of the things that really inspired us is like we want to have collective action, because it takes different actor groups. And so we are inspiring collective action to provide a roadmap to improve the well-being of the health workforce in order to ensure that health workers can properly care for their patients and promote population health, while we are also at the back promoting their health and making sure that we're prioritizing the well-being of the health workforce. And so the national plan, and Dr. Sheila spoke about the drivers for success. The national plan has 7 priority areas, and that's what you see on the screen. The first one is to create and sustain a positive learning and work and learning environment and culture, to invest in measurement, assessment, strategies, and research, to support mental health and reduce stigma, address compliance, regulatory, and policy barriers for daily work, engage with effective technology tools, institutionalizing well-being as a long-term value, and that ties with the laying the foundation for a long-term culture change, and finally recruiting and retaining a diverse and inclusive health workforce. So these are the priority areas. The national plan has goals and actions and just gives like some guidelines on how to be able to move these forward. Like I said earlier, the goal is to inspire that collective action. And so the national plan calls out different actor groups that will be able to move these levers forward and ensure that the health workforce is being prioritized and their well-being is being prioritized. So some of these include the federal, state, and local government. We have health IT companies. We have patients themselves. We also need to hear from the health workers themselves. So we are including everybody. And so as I'm ending, we have different stakeholders that we're working with to ensure that this work is moving forward, and we're not just having the national plan. We are moving forward. We are making sure it's being implemented. So in October last month, we celebrated our first anniversary of the national plan's release. And since its release, we've been working behind the scenes with different stakeholders, as I mentioned earlier, to ensure that they're moving these forward and they're prioritizing the health workforce. So we actually have, we launched our Changemakers campaign that is meant to be able to kind of spark a national movement to support the health workforce well-being. We have different events and convening that talks about different workforce issues in rural areas and different settings, and also something that is very exciting is that we are planning a national day for health workforce well-being that is going to, we're working with the federal government and national partners to be able to make this a truly interprofessional day for everybody, so that we're including the whole health workforce, and we are propelling solutions and driving it forward. As I end with this, I just wanted to end with a quote that the National Academies has in all their publication. Knowing is not enough, we must apply. Willing is not enough, we must do. And this is by Goethe. And so as I transition to Dr. Pittman, I just want us to also like have this quote at the back of your mind. So I will turn it over to Dr. Pittman.
Thank you so much. Good morning, everybody, or good afternoon, or we passed the noon hour, I guess. Good afternoon. So I will try to provide perhaps a deeper dive on a few of the issues that Sheila mentioned. The programs that HRSA has that really target the maldistribution and the problems of access are critical to this nation, and they're very different than the programs coming out of other parts of HHS. They're primarily focused on primary care, which is what we need to have built up, but I do want to just sort of have a moment of sort of recognition of just how critical the work is that HRSA is doing. And I don't do this, say this as a grantee or a friend. I say this as a American who really cares about the healthcare workforce. HRSA does an incredible job of helping us redirect the workforce to population needs. So I'm going to talk a little about maldistribution and attrition and some of the policy levers to address them. This is a framework that we use at the Mullen Institute at GW, and the idea is that health workforce issues are more than just a shortage. There are all kinds of issues, from who enters, how they're trained, how and where they're deployed, whom they serve, how they practice, and under what working conditions. So workforce is a broad area of policy. It's not just produce more warm bodies. So on the issue of the physician shortage, there are lots of projections, and the new projections out of HRSA are really interesting and important to look at. But we know that we spend a lot of money training physicians. And this is just, where we go. This is just sort of a summary of the different programs and what they amount to. So we spend annually almost $21 billion training physicians in this country. And the question, and this is apart from what HRSA does on pediatric training and the teaching health centers, which is a residency in community health centers that are very important and distinct. So it's really important to see what we get for that. So these are the residency matching numbers from 2023. And what you can see here, obviously, is that family medicine, internal medicine are not as popular. So we have a problem of graduating physicians who are not as interested in going into primary care. This is an age-old problem. It's not a new problem, but it is chronic, and we are having a difficult time addressing it. COGME recommends about 40% of our physician workforce should be primary care. When we are graduating folks from the residency, it actually adds up to about 54%. But after the residency, so we have a problem in residency and matching. When you include OBGYN and PEDS, it actually goes up to 54, and then we lose them through the specialization process. And this is largely driven by the issue of income. So we have a problem in the way we pay physicians because it's driving the maldistribution by specialty. It also is driven by geography. If you look, for example, at the Milbank's scorecard on the number of primary care physicians per 100,000, just really briefly, you can see that there are incredible sort of differences across states in terms of access to primary care. So we have a huge problem of geographic inequality. And when you think about this other dimension of whom they serve, we also have a problem of physicians and organizations that physicians work in not being willing to serve Medicaid patients. And so you can see here, this is a tracker that we've just released at the Mullen Institute. You can look by profession on the left-hand side, family medicine, internal medicine, pediatrics, OBGYN, and sort of click, and the map will change into the density, as well as in the volume of Medicaid patients that they see. But it's really important to note that there are many professions that have, they're about 30% of their clinicians are actually not seeing Medicaid patients, and that's a problem. So whom they serve also really matters. It's not just having the warm bodies in a particular district. So what are the policy levers? Obviously, we've got a lot of money at stake here if you think about the graduate medical education bucket, and there's a lot that could be done to make sure that we get more on that investment in terms of meeting the population needs. And there's an IOM report, now called National Academies of Medicine, that lists many recommendations that were produced by experts and researchers, and those recommendations have sat on a shelf for over 10 years, and really there's very little movement in this area. The targeted health workforce programs that HRSA does are incredibly important. Community partnerships that HRSA does are incredibly important. And then on the practice side, we need to really be thinking in a much more focused way on advocating for higher pay for what matters, in particular primary care, mental care, care in rural areas, and care for the underserved. We need targeted practice supports. The ECHO project, which provides educational support in real time to clinicians in underserved and rural areas, is a real sort of stunning success. Telehealth obviously holds lots of promise as well, and scope of practice reform so that nurse practitioners and other kinds of advanced practice nurses and PAs can practice to the full extent of their education and license. Just to focus briefly on nurses, the story is rather different. I think that many people today would agree that it's largely a problem of the working conditions. We have a lot of nurses in this country, and almost 1 million of them are not practicing. They're licensed nurses. So we have a pipeline problem, yes, but what we really have is a problem of attrition. So on the issue of distribution, it is like medicine, it is not the same across states, and HRSA's projections show that in particular the shortfall is greatest in Washington. We do have oversupply, nevertheless, in a few other states. So looking at distribution again for the nurse workforce is really important. But basically in terms of the pipeline, we are not far from meeting our needs. If we produced 195,000 nurses a year, we would be meeting our needs going forward. And we actually produce in the high 180s now. And we have in the last 20 years been increasing the number every year. So the programs that are addressing the bottlenecks in the pipeline that HRSA does, including the nurse faculty positions, are really important. But it's not the main problem. The main problem is the leaky bucket. So we know that in 2021, we had over 100,000 full-time nurses that left nursing, and that most of those nurses were under 35. Most of that attrition happened in hospitals, and the hospital vacancy rates continue to be really high. So we know that 39% of nurses are planning to leave in the next year, and 28% plan to reduce hours. Now, plans are not always materialized, but these are what people say in surveys. 60% of critical care nurses in ICUs are planning to leave in the next year. We have a real problem in terms of attrition. The number one reason that people say they are leaving is inadequate staffing. There are a couple of other things that are worth noting in some of the surveys. Of those who reported frequent mandatory overtime, they were 72% more likely to have quit in the last 2 years. As you all know, some states have mandatory overtime prohibited and others don't. Those who reported less favorable work environments were 55% less likely to have quit. Moving on here because we're running out of time. I think the main policy levels here are safe staffing ratios for hospitals. This can happen through Medicaid. It can happen through legislation at the state or the federal level. We need to measure staffing levels. We need to measure turnover, and we need to include it in comparative hospital statistics like Hospital Compare. And eventually, I think about including it in value-based payment schemes. We need to reduce burdensome regulatory and accreditation processes. We need to have better protections against violence and harassment, whistleblower protections, and then we need to incentivize organizational change. And we can talk more about that perhaps in the Q&A, but there are lots of ideas of ways that the federal government could encourage healthcare organizations to do a better job in terms of both staffing and other sort of more general working conditions. Thank you.
Good afternoon, everyone. I wanted to, I told you I was going to do this. I wanted to first say, good afternoon. I wanted to first provide a brief overview of our healthcare system. So Trinity Health, who I represent, is one of the largest Catholic healthcare systems in the United States. We are a family. We're a family of 123,000 colleagues that come together and more than 26,000 clinicians caring for diverse communities across 27 states. We're nationally recognized for care and experience, and that includes our 101 hospitals and 126 care locations. And we also have our PACE program. That is also the second largest program of all-inclusive elderly program in the country as well. So I know that we've talked about a lot about our healthcare shortages in the country, and what Sheila has said and what Dr. Pittman has already articulated, these things are not new. We did come together at Trinity to try to think about our workforce just a little differently because, as Dr. Pittman has outlined, these issues are multifactorial. It's not something that is a one-size-fits-all as we think about workforce challenges as it relates to healthcare and our healthcare professionals across the all disciplines. So at Trinity, we thought about all of the communities that we serve. We thought about how could we start to look at this and think about this differently. And what we do know, even though there are ways to look at the nursing shortages differently, we do know we have a problem. And what we started to think through is saying, okay, what could we do to at least look at our workforce for nursing differently? So we thought about the innovative approach that we can take to Together. We call our approach Together Team, or Together Team Virtual Connected Care. It's a 3-person care team model where we have a bedside RN, an RN partner, and a virtual nurse. And the value of all of the teams, or these people, these actors working together on this team, is that the team is looked at when they're working together as a team. They look at workload, and their workload is balanced through the team, how they take care of the patients that they have. The other piece of the virtual nurse specifically is that virtual nurse can also provide that experienced nurse to earlier career nurses that may be on that team. And also provide that mentoring, that early mentoring that new career nurse may need. So as these are the 4 tenets of the model: culture, people, technology, processes. And these are things that are not new to anybody who's looked at processes and technology and culture as you look at anything with workflows or when you look at any type of initiative such as this one. The innovation actually comes in when we start to think about the way that the model is implemented, the way the team looks at their workload, and how they bring these actual pieces together. We are committed to listening to our colleagues who are nurses. We are invested in the culture to keep our nurses safe psychologically and in their environments. We want to make sure that they feel empowered to take care of the patients in the communities that we serve. At the current moment, we're live in 8 states, and we have approximately 173 virtual nurses on board. The one thing that you learn through an innovative model is that you learn something literally every single day. So we are pivoting, learning, reincorporating our learnings every day, literally. And we are teaching and just re-innovating and as we implement, as we move along. These measures are our leading and lagging indicators, and we look at the areas of impact to our colleagues and to our patients. And these are ones that we've just defined in this phase of our innovation. But again, as we learn forward and as we lean into what we define as our pathway to success, we learn from our measures, and we definitely will reroute or redefine them as we learn into our new model. One thing to mention too, as we start to look at some of the earlier insights that we've learned from our program, we do have decreased, we've seen that we have decreased RN turnover. We do have increased patient satisfaction. But like I said, these are very, very early insights into what we've learned today. One quick, I won't read the whole slide, but this is one of what innovation actually looks like when things start to come together. This individual was somebody who was a skeptic. He actually was a person, Stephen was one of the maintenance mechanic that actually helped us install the very cameras that we used in our program, and he ended up being a person who was a patient in one of our hospitals. And then while he was implementing this, helping us implement this program, he got ill. This actually he became a believer after he actually experienced the model. So he became a skeptic. He was a skeptic and then actually experienced the model and then figured out that, wait a minute, this wasn't half bad. It was interesting to see that and hear that from him, especially working as closely as we did with him. So really quickly, what could be done, and what levers can be pulled or used in support of what we're trying to do, is to really fund these type of initiatives. They're really important as we start to think through all of our workforce challenges. I know Sheila and Dr. Pittman talked about all the good work that HRSA is doing with building that strong pipeline. We continue to support those type of programs. That would help a lot to help in this space as well, and also building up that resilience in the workforce and in the existing workforce as well. And now I will turn it over to April.
Okay, always a challenge to be the last speaker when people just finish lunch, so I will try my best. So as mentioned earlier, so I oversee the Weitzman Institute, which is a research education policy center. We have different offices. I'm based in one here in DC. And our priorities are to focus on optimizing health outcomes, particularly in vulnerable populations. And so our 3 priority areas are in social determinants of health, workforce development, and systems transformation. So our founding, the Weizmann Institute, we were founded out of a federally qualified health center, Community Health Center, Inc., in 2007, which is based in Connecticut. We continue to focus on FQHCs, which arguably are the backbone of America's safety net system. So if you're less familiar with FQHCs, just a brief background. FQHCs nationwide serve about 31.5 million Americans, largely vulnerable, marginalized populations. 2/3 identify as people of color. 68%, or another 2/3, fall below 100% below the poverty line. About half are on Medicare, and another quarter are uninsured. And so during the pandemic, I know we've heard about workforce shortages. It's actually gotten worse. So the latest workforce survey that was done by the National Association of Community Health Centers, or NAC, noted that 68% of health centers across the country reported a 25% attrition rate. So they lost up to 25% of their workforce during the pandemic. And so I think it's important to note this, because when you have a workforce that is working with the most chronically complex patients in the country, it's important to know, how do we support this workforce? And so today, as part of talking about patient-first healthcare system, I really want to focus in on community health workers, or I'll be referring to them as CHWs, probably not new to this crowd, to really understand what their role is in building a robust healthcare workforce that not only supports the workforce, but also patients most in need. So part of the challenge right now with us falling short of a person-first healthcare system is that leadership, as well as those who are patient-facing, don't necessarily relate to or represent the lived experiences of the patient populations that they're serving. And it's particularly true in marginalized and vulnerable populations, right? And so there needs to be some bridge building in terms of how do we make the workforce that is facing patients better relate to or representative of the patient populations that they're serving, right? And so CHWs, which are now a bona fide workforce according to the Bureau of Labor Statistics, there's 86,000 CHWs nationwide. In the American Rescue Plan, there was a call from the White House to add another 100,000 CHWs. They usually share, as noted in the keynote, the ethnicity, language, socioeconomic status, and life experiences of the communities that they're serving. So about 45% being bilingual, and another 75% identifying as a person of color. So CHWs, as you may know, have recently garnered a lot of attention because of the increased attention towards health equity, particularly social determinants of health, and realizing that CHWs can play a role in addressing and moving the needle on health disparities. And so when I was broached with this topic, I wanted to make sure that when we're talking about a person-first health system, that we talk about or include the voices of patients themselves, right? And so a lot of all the quotes that you'll see in the next few slides come from a study that we did at Community Health Center, Inc., where we actually interviewed patients, diabetic patients who were managed by one of our CHWs, Lenore. And so I've noted the citation of our article there if you're interested. And so over the next 3 slides, going over how CHWs add value to the system through 3 areas. 1, addressing social determinants of health, or SDOH, improving health outcomes, and last but not least, restoring the healthcare's system trustworthiness. So before I joined Weizmann, I actually oversaw the SDOH portfolio at the National Quality Forum, and so oversaw the development of the first quality measures in SDOH. And as many of you know, SDOH being the factors, the upstream factors where we work, live, pray, play, and age, account for 70 to 80% of healthcare outcomes, right? So it's not enough to focus on the 4 walls of clinical practice, but looking upstream. And I remember one of the challenges when I was working at NQF that was brought to my attention from clinicians is saying, okay, even if we screen patients for SDOH and we identify patients who are positive for housing insecurity, food insecurity, and other challenges, how in the world do you expect us to address these and close the loop on referrals in a 15-minute visit with the million other quality measures that we're expected to report back to our funders, right, or to health plans? And so just knowing that CHWs are really a trusted members of the community, that they have nuanced understanding of community resources and how to address these different social challenges. And so during the interviews that I conducted with Lenore's patients, some of them talked about having challenges with transportation, and not the reason that Lenore is able to find out from them that the reason they were missing their appointments was because of lack of transportation, or that these appointments were being done in the middle of the day and that they couldn't take time out of work, being hourly workers, to be able to make their appointments. And so when our healthcare system would otherwise label these patients as non-compliant or no-shows, really understanding what are the root causes of why these patients aren't able to make their visits, right? And so I attempted to include a quote here that captures that notion. And so by addressing these root causes, CHWs have been shown to save Medicaid $4,246 per beneficiary. So if we scale that up to 15% of US Medicaid beneficiaries, that would save taxpayers $47 billion annually. And so I just captured here, you can take a screenshot, that there have been RCTs and different studies that have been done to show the return on investment when we really look at CHWs, and include a quote here in terms of diabetic patients whose hemoglobin A1C significantly dropped as a result of working with Lenore. And so my last point about CHWs is the importance of restoring the health system's trustworthiness. And note that I didn't say having patients better trust our healthcare systems, right? And really the onus is on us, and knowing that trust cannot be earned overnight. 15-minute visits with your healthcare systems or with the healthcare teams is not enough to build trust. And so what does it mean for CHWs who mirror the demographic makeup of the patient populations they're serving to be able to have the linguistic and cultural sensitivity of the patients they're serving to actually be part of a team-based care model, right? And so really understanding how do we recruit a more diverse, robust workforce that better looks like the patient populations that they're serving. And so in closing, I wanted to know 3 recommendations of where do we go from here. So one is proper training, right? At Weitzman, we do a lot of upskilling. Dr. Pittman talked about Project Echo, so we provide those services with CHWs. And knowing that we need to, something happened to the slide. Okay. Not sure what happened. Okay. Well, I'll just, okay. Yeah, so understanding that we need to invest in CHWs, right? It's not enough to recruit them, but also retention is important, upskilling, making sure that we're investing the proper resources so that CHWs feel as a valued part of the healthcare team. I would say the second is expanding the scope of practice, really understanding that there have been recent studies in terms of the role of CHWs, not just in addressing the upstream factors of SDOH, but also addressing major challenges from mental health, substance use disorder, maternal child health. And then the third, as selfishly as a health services researcher, knowing that we need to improve and invest in building the evidence for CHWs, right? To be able to advocate for CHW workforce sustainability means building the evidence of how do CHWs work, in what capacity, and for what health conditions. So knowing that by investing in the CHW workforce is really helping to advance health equity and also a person-first system. Thank you.
Thank you so much. So can we all give them a round of applause for this wonderful? Thanks. So we got to hear, and thank you once again for setting the stage and giving us context and a wealth of information. We heard mainly that this is a multifactorial issue, and like there's a lot of things that could be done. there's no one way of going around and solving this problem. And so as I kick off today's Q&A, I just wanted to start with this question. Acknowledging that is a bit dreamy, but then we can hope. And so what is that one action, or like what is that one strategy that can thread everything together in order to kind of move the wheel and help us get to that person first health system? And I think, Dr. Patricia, would you like to start it off?
What a question. Oh my goodness. To get one thing that has to do with the workforce shortages that relate to person first. Well, I would go to where the money is first, to tell you the truth. I would go to GME and I'd unpack that and I'd rebuild it.
Is there anybody else that would like to address this?
I agree.
Yeah, I definitely agree also with, like, you have to go where the money is and be able to distribute it through a health equity lens as well. And so with that, I'll just open it up to the audience and take some questions if there are questions. You also have some white sheets on your table, so you could write your question as well if you'd like. And yeah, we open it up.
I'll ask the question because I'm not shy. Okay, so y'all, you have these. If you're shy, you can write your question down, and someone will come pick it up. Okay, but if you're not shy, and we welcome everybody. I have a question. So you mentioned. Thank you all so much for your presentations, for your work in this. I'll just go right to like where some of the controversy is around scope of practice, right? Like, I mean, we can talk about shortages in absolute numbers, but then there's, you mentioned CHW scope of practice. Like, this has been a conversation that's been kind of stuck for a really long time, right? Do you see any movement in it? Do you think we're sort of starting to get to the point where, like, we're in a place where we can actually have some movement to help people sort of to free and liberate sort of the people to practice at the top of their licenses, and really then thus free up the time of, the people with the most specialization to do what they really need to be doing? Like, what does that conversation look like as we move forward, and so that the people who are sort of on the front lines of dealing with it from a policy perspective, like, how do they start to address some of these questions?
You want me to go for it? So there actually has been a lot of movement on scope of practice, particularly for nurse practitioners and physician assistants, or now physician associates. Less so with nurse anestheticists because of the opposition of anesthesiologists. I think it's one of the few areas of health policy where there's bipartisan support. It's an issue of the free market. The problem, of course, the AMA is seeing that this is happening, and they've just stood up this big campaign to oppose reforming scope of practice laws in the states that still have restricted laws. And it's something that I think is really felt by their grassroots membership. It's an authentic concern, and their concern is that this is cheap labor replacing them. So I think, I personally believe that the evidence is incredibly robust, that nurse practitioners and physician assistants can do a really good job, particularly in primary care, and supplant some of the work that physicians are doing. But it's been such an either-or debate that it's really been hard to get at, what are the best ways to put together teams? What are the best ways to, how does this relate to, comparing actual care delivery models and looking at outcomes over time, and we need more evidence on that. Not just the all or nothing scope of practice issue, I think, is a really, really important thing. But there's no denying that the train left the station. In terms of the number of clinicians, primary care clinicians that are growing in this country, it is nurse practitioners. It is not physicians. The physicians have been flat. Nurse practitioners have taken off. In terms of the people who actually see poor people, Medicaid, it is 95% of the growth of the primary care Medicaid workforce are nurse practitioners and physician assistants. It just is happening. It's happened. And so I think it would be helpful for the AMA to change gears and begin to talk about how do we make this happen in a way that is best for all clinicians and for patients, and not just, absolutely not. We're not going to look at this issue at all, and no, 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 no.
The one comment that I would add to what Dr. Pittman said is that also allowing the permission or the space or that innovative space to allow these type of models to grow and to enculturate as well, because that's the only way that we're going to learn of how people can use and work at the top of their license, and then giving that permission to then having the right people doing that right work within those models. And then to Dr. Pittman's point of studying that and looking what the impacts are on outcomes, we need the permission and space, and we need the funding to support those type of efforts. Those things are pretty much far and few between. People are kind of doing them on the side of their desk. If we had a concerted effort of how we could get that type of work more organized to do that, it would help as well.
And the other thing is the graduate medical education versus what NPs and PAs are getting post-graduation is shocking and scary. HRSA does have a primary care nurse practitioner residency program, but it's peanuts. I think graduates, and Margaret Flinter leads it, and I don't know, maybe 60 or 70 NPs graduate a year, and they are true believers that makes all the difference in terms of patient outcomes and patient safety, and the nurse practitioners feeling confident in their roles. But as a federal government, we're not investing in any real way in graduate nurse practitioner or physician assistant education. So there's a huge, and the contrast with how we use taxpayer dollars for physicians is shocking.
I'll just add in terms of CHWs that I had to mention in the beginning of my talking points that they're now recognized in the Bureau of Labor Statistics, but CHWs are not new to the workforce in general, right? I think the U.S. is actually behind a lot of low middle income countries. Like CHWs have been around for decades. Promotoras, right? Health promoters, lay workers. Like, this is not new. It's new to us, but not new to the rest of the world. And so we wrote actually an article in Health Affairs you can look up. We just laid out the evidence. We couldn't take a position because it's very challenging, because some of this varies by state in terms of CHW certification and competencies. The American Public Health Association has had an interest group on CHWs for decades. So it's, to your question, it's progressing, but very slowly. The White House, explicitly calling out the need for CHWs in response to the pandemic, right? Whether that be educating to counter misinformation, to administering vaccinations. So we're seeing more traction. The challenge is that it's still not agreed upon in terms of what exactly do CHWs do and don't do, and knowing that at the end of the day, it comes back to the money, right? Like, what is billable services? Who's going to pay for these CHWs? They sound like a great idea, but if you don't have like a Medicaid, 1115 waiver to cover the SDOH related efforts, how are you going to pay for CHWs to retain them, right? I think that's part of the challenge with the workforce shortage and scope of practice, that we do a lot in terms of recruitment, but retaining the workforce, I think, is where we start bleeding a lot, and not investing in CHWs and how do you pay for services that they provide. Because certainly with Lenore, we had to pay for it creatively, I would say, through a state-based grant. And so it's very challenging in terms of how do you build out a robust CHW workforce within a busy practice.
Thank you. We have a question.
So, thank you. Building on the comments that you just discussed, so I'm a nurse practitioner, and I wonder if the shift to accountable care payment arrangements is going to facilitate team-based care. I'm also a palliative care nurse practitioner, so I'm used to practicing with physicians. social workers, community health workers. And I think if we could shift to a model that paid for teams, we could figure out who needs to be on the team and then who needs to see what patient. And so physicians would have an important role on that, although I might add, not as the leader, the automatic leader of the team. That's something that interdisciplinary teams often don't need a leader. But I think that there's a way to work collaboratively and let everyone practice not only to their highest scope of practice, but also move the work down to the right level. There are things that nurses could do that neither physicians nor NPs should be doing, but under the current fee-for-service system, we do because we get to bill and they don't. So can you comment on, am I just waiting
Yeah.
for a future that's not going to happen, or do you think that might be one solution?
I mean, I'm interested to hear if Trinity is shifting the way they use NPs as a result of any sort of participating in ACOs or any other kind of value-based payment. But in general, I think, 10 years ago when ACOs began, everyone thought that it was going to have this incredible change in terms of how the workforce was configured, and that we would be using RNs in primary care, and that NPs, would be going much more integrated teams. And I think in general, people have been disappointed that there hasn't been as much transformation of the care delivery as they thought. And however, actually, we just finished one study that shows that you do see much more home care from NPs and physicians in ACOs than those that are not under the Medicaid ACOs, which is interesting and encouraging. So that's a big change. But I think that the problem is that it is because payment is so fragmented with all the different payers. Even if you are an ACO under Medicaid or Medicare or a private insurer, it doesn't relate to your entire patient population, and therefore the incentives, we just haven't gotten to the tipping point. And I think that's the story with value-based payment in general and why it hasn't affected the workforce as much. I've been an advocate for having more proximal outcomes in our value-based payment. If you want to have a social worker on the team, don't just pay for outcomes, pay for, or require that there be a social worker or that there be a community health worker. And, I think that goes against the grain of sort of the economists don't like to dictate what folks should do. They want to just provide a reward at the end of the rainbow. But the problem is it's just not enough money to change behaviors. So if you have very little money, you might as well tell them what you want.
Dr. Bean, do you have anything to add on to that, or?
Actually, I was going to ask my colleague that's in the audience that probably knows a little bit more than I do for her to respond.
Sure.
So, Maggie. She's a little bit more closer to these type of policy matters.
Thanks, Muriel. So actually, Trinity Health is one of the leading systems in value-based care. I guess if we call it that, I think that's even a question of what do we even call it. But yeah, we have clinically integrated networks in most of our states, and we have some really strong experts in population health and how do we do this and make it sustainable. I think that's the biggest problem is our system is still so fee-for-service heavy. And so to think about a 27-state system trying to make this sustainable and to be doing this all day, every day, we're just not there yet. And so we always try and think about how can we focus on our APMs that we're working on now, and we're in every model that CMMI has ever put out. But how do we focus on being sustainable now while we kind of bridge to that future where hopefully ACOs and other APMs are kind of the norm. It's really that really tough time for hospitals. How do you get to that phase? Because for a model like virtual Together Team Virtual Connected Care, that's the whole point, is really to be able to have that team-based care and have the work where it should be. But we are far away from being in a payment system that fully supports that.
Thank you so much for that. We have a question right here, and I think it goes to Dr. Trinity Health. Are there any estimates of how much money, or Dr. Pittman can answer this as well, how much money is wasted when we lose these healthcare workers, when we are not able to retain them, and like how much does it cost to kind of go and recruit again in that turnover rate?
Yeah, the general estimates I would have to look up though, because we had just done this analysis. So I would, if I could have a minute, I can look it up actually.
Well, in the meantime, there's a NBER paper that just came out that tries to quantify the cost to healthcare systems of attrition due to burnout.
Yeah.
And the first thing that they measure, which is traditional, is the cost of a turnover. And in the case of nurses, it's about $52,000 a year as of 2023. But in addition, what they did, which was kind of innovative, is they looked at the effect on patient satisfaction and the effect on, I think there was another outcome as well, and translated that into payments that systems would not be receiving as a result of falls, declines in their quality scores. And so anyway, it's a whole methodology if anybody's interested. I know Cece Hu is an author, Tiffany Chen is an author, NBER. You can Google it.
Thank you for that.
So our organization, same with just Dr. Pittman just said, we looked at a whole host of, and they're still doing the analysis is why I don't have it. Because we look at not only the cost of turnover, but there's a lot of things that go into the quantification of how much that actually costs the organization every time that we have a RN turnover. And so I know the estimates were almost about $70,000 per RN turnover,
Yeah.
which is pretty high if you start to do the multiplication over 27 states times thinking of the units times. So you could also think exponentially how much that costs a healthcare system.
Yeah, I think that's why it's very important to retain the health workforce system, and also show this to leadership if you're trying to obtain leadership buy-in, and emphasize that return on investment when they retain that members. I think we're out of time right now, but is there a last question? Yes, we have a last question here. Yes.
Sorry, I have a final
Oh.
question. I'm really interested in the concept of telehealth and how that might possibly help with some of the workforce shortages. But I also understand state licensing restrictions, and interstate practice issues and all of that would come into play. Is there anything that can be done at the federal level to help alleviate some of that?
You mean in terms of well, there's a movement towards compact licensure, and that's really going to help. And it's largely a result of recognizing the importance of telehealth. But I think, the issue of parity in payment for telehealth is huge, and that's absolutely a Medicare issue and a Medicaid issue. But I think we saw during the pandemic, there was this skyrocketing in the use of telehealth, and it was actually really beneficial in terms of improving access. And it's now come down a little, but as a result, consumers and providers' attitudes have changed. And I think there's a lot of excitement about making sure that, that the payment is adequate to be able to continue to incentive. I think there's some concerns about fraud, that it could be overused. MedPAC is concerned about fraud, but so there'd have to be some checks and balances. But I think overall, it's really promising in terms of addressing some of the workforce shortages for sure.
Thank you for that. I think we have time for one more question, so right there.
I have one question for clarity. Someone said that there were more nurses in Washington. Did you mean Washington State or Washington, D.C.?
State.
State.
They're going to have a shortage. They're one of the worst shortages, yeah.
I think we have time for one more question. I saw your hand up.
I was just curious, could you talk about the role of patient-reported outcomes and patient-reported outcome measures in person-centered care, things like tools that Phreesia and Promise are developing? I'm curious, specifically with Dr. Bean, if you see a role in some of the new models that Trinity is working on in proms.
There's definitely a role in that, and we actually it's in our second phase because we're thinking about that, and so we've been working with our EHR vendor on how to think about patient-reported outcomes. It's one of the pieces of stabilization I think will be critical. I know it's a very hard concept for people to get their hands around, but it's definitely something that we have framed in our second phase of our implementation. So thank you for the question.
Well, I think we are at time. Thank you so much to everybody for your time, and thank you to our wonderful panelists for your input and insight. So I will turn it over to Sarah right now.
Great, thank you. Thanks so much, Freddie. Thank you so much to our panelists. Can we give them one more round of applause? Thank you. Thank you. I think it's so clear that we are asking so much of our healthcare workforce, and to really see the numbers really puts it into stark perspective. And so it's really heartening to hear about some of the innovations to try to both build the pipeline and retain the workforce, but also I think it's obviously so clear that we have our work cut out for us. We're again grateful to all of you, and to Sheila, who was here earlier, for an enlightening discussion. Thanks to all of you for your questions too. And I just want to encourage you to think of the Alliance for Health Policy as a resource. Check us out online, send us a note if you have questions about, whether it be telehealth licensure or patient-reported outcomes. Chances are we've done a briefing on it at one point. We know experts on it. We have a database of over, hundreds and hundreds of experts from across the country that, our team will try to get back to you as quickly as possible with information and resources, or connect you to someone who does have the answer to your questions. So again, do check us out, and also all of our past briefings are pretty much available and free online if you want to check out our archives at allhealthpolicy.org. And I know someone for you, and I know some people for you too. So check us out. Okay, so this has been the final briefing in our 2023 signature series on envisioning a person-first health system. We're really excited that we will, in the coming couple of months, we will be issuing a report of the 2023 signature series. It's going to include some of the hallmarks that our thought leaders really came up with, and I think you'll be very interested and surprised to see how much alignment there is across multiple sectors of the healthcare system, industries, community leaders, et cetera, that there really is quite a lot of alignment, and I'm hopeful that you will all take the time to read that when it comes out, and really kind of consider how it might be useful in your work. So in the meantime, we have some quizzes on the tables. Those are really just evaluation forms. We would love for you to fill that out. You will also get an email if you prefer to do it electronically. We just like to sort of combine the old world and the new world here, paper versus electronics. But do fill it out. We like to consider ourselves a learning organization, so we take it all into account. And so with that, stay, network a little bit longer, grab some food if there's still some left, come back to our future briefings. Let us know what you want to hear about and learn about. We take that all into account in our programming. Thanks again.